Hi, my name is Laura, and welcome to my audio study guides. Today's topic is meningitis. Meningitis is an infection of the meninges. It's divided into bacterial meningitis and aseptic meningitis, which includes viral and fungal etiologies. Let's start with bacterial meningitis. Clinically, these patients will present with fever and chills and meningeal symptoms, often a headache, nuchal rigidity or stiff neck, photosensitivity, nausea and vomiting, and sometimes altered mental status or seizures. Koenig's sign and Brudinsky's sign are buzzwords here, because even though they're not common, if they are present, they're very specific for meningitis. A positive Koenig sign is the inability to straighten the knee without causing pain. Koenig, can't straighten knee, causes pain, Koenig. A positive Brudinsky sign is when flexion of the neck causes hip or knee bending. Brudinsky's bending. Now on to diagnosis. While a head CT is often done first, definitive diagnosis of meningitis is actually made by lumbar puncture and cerebrospinal fluid, or CSF, examination. However, do not wait for lumbar puncture results to start empiric antibiotics if you suspect bacterial meningitis, since early antibiotics have been shown to increase survival rates. Bacterial meningitis has common pathogens and empiric antibiotic treatment algorithms that are based on age group. We'll go over those now. In newborns who are less than a month old, the most common pathogen is group B strep. Other pathogens include Listeria monocytogenes, E. coli, and strep pneumonia. In this age group, empiric treatment is ampicillin, plus a third-generation cephalosporin or an aminoglycoside. In patients aged 1 month through 18 years, the most common pathogen is Neisseria meningitidis, which is associated with a petechial rash. Other pathogens include strep pneumonia and Haemophilus influenza. In this age group, empiric treatment is a third-generation cephalosporin plus vancomycin. In patients aged 18 to 50 years, the most common pathogen is strep pneumonia, but Neisseria meningitidis is also common. Other pathogens include Haemophilus influenza, Listeria monocytogenes, and gram-negative rods. The empiric treatment in this group is the same as the last group, a third-generation cephalosporin plus vancomycin. In patients older than 50, the most common pathogens are strep pneumonia, Listeria monocytogenes, and gram-negative rods. In this age group, empiric treatment is ampicillin plus a third-generation cephalosporin plus or minus vancomycin. So just to recap, in neonates less than a month old, group B strep is most common, and they get ampicillin plus a third-generation cephalosporin. In kids 1 month through 18 years, Neisseria meningitidis is the most common, and they get a third-generation cephalosporin plus vancomycin. In patients 18 to 50 years old, strep pneumonia is most common, and they get a third-generation cephalosporin plus vancomycin as well. And in adults over 50, strep pneumonia is the most common, and they get ampicillin plus a third-generation cephalosporin plus or minus vancomycin. So that was a lot, but there are 2 more drugs to know for bacterial meningitis. So first, the steroid dexamethasone is recommended to reduce the risk of neurologic complications, especially if strep pneumonia is known or suspected. And if exposed to meningitis, the antibiotic ciprofloxacin can be given for post-exposure prophylaxis. So as we said, a lumbar puncture with CSF analysis is the definitive diagnosis for meningitis. The CSF analysis can also be used to differentiate between bacterial, viral, and fungal etiologies. In bacterial meningitis, the opening pressure will be increased and the CSF will appear cloudy. It will also have a high protein and low glucose level, since bacteria eat up all the glucose. And white blood cell count will be very high with a predominance of neutrophils. Now let's move on to aseptic meningitis, specifically viral meningitis. Clinically, this presents with headache, fever, mild confusion, and meningeal symptoms like nuchal rigidity, positive Brudzinski's and Koenig signs, photophobia, and lethargy. And these symptoms are not as severe as bacterial meningitis. The most common culprit is the enterovirus family, but other causes include arboviruses, herpes simplex, virus 1 and 2, and HIV. Now diagnosis. A head CT might be done first, but again, a lumbar puncture and CSF analysis are the definitive diagnosis and can differentiate between bacterial and viral etiologies if it's unclear. In viral meningitis, the opening pressure is normal or slightly increased, and the CSF will be clear. It will also have normal or slightly increased protein and a normal glucose level. And the white blood cell count will be high with a predominance of lymphocytes. Treatment for viral meningitis is mostly supportive, with antipyretics, fluids, and antiemetics. It's usually self-limited and has a good prognosis. Now a quick review on the differences between bacterial and viral meningitis on CSF analysis. Bacterial meningitis has cloudy CSF fluid with a significantly increased white blood cell count that shows mostly neutrophils. Viral meningitis has clear CSF fluid with an increased white blood cell count that shows mostly lymphocytes. Bacterial meningitis has significantly decreased glucose and very high protein. Viral meningitis has a normal glucose and normal or slightly increased protein. So basically, if the glucose is normal, suspect viral meningitis. And if the white blood cells are predominantly neutrophils, suspect bacterial meningitis. And that wraps up the meningitis topic. If you enjoyed this content, feel free to subscribe, check out my channel for other topics and study guides, and thank you so much for listening. Happy studying, and I'll see you in the next video.